Our department is using most of the training on mannequin and simulation. Definitely we don't have the whole machine, but thanks to the effort of Professor Islam Masad, every student had the chance now to go for 1 week to the skill lab. Now, from beautiful Germany, we fly to dance of pyramids. So Dr. Yahia Balbaa from Egypt is going to talk about the financial problem of training under the title Training of the Surgeon Who Pays the Bill. Dr. Yahia.
First of all, Dr. Islam, thank you very much for inviting me to this Congress. Dr. Bashir, thank you very much for the session. I'll just correct who pays the bill. I didn't mean the financial aspect. I mean who pays the bill, as I will see. First of all, this is my Faculty of Medicine, where I am proud to be. I'm from Cairo University School of Medicine, which is since 1827. I would like to start my presentation by this painting for an anatomy lesson in 1829 in my School of Medicine. First of all, I would like to shock you. In 2016, where we have the progress in medicine, this study showed that in the United States, in 2013, medical errors was the third cause of all mortality. This paper in the European Journal of Thoracic Surgery estimated that every year 234 million surgical procedures are done all over the world. Around 1 million patients die due to surgery, which is a very good result. 7 million patients develop complications, and it is estimated that 50% of all those surgical complications are preventable. This is against the oath of Hippocrates, which is the first rule: we should not harm patients. Obviously, doctors are harming patients all over the world. When I was lucky to train under this great man, who happens to be my father and my teacher, Professor Dr. Balbaa, and the first rule he taught me was, if people have to die so that you learn, it's better that you don't learn at all. The learning curve obviously has victims. I remember this girl, and I would like to share her story with you. I was a junior resident of cardiothoracic surgery, and I had a beautiful girl, 5 years old, with tetralogy of Fallot. She went into surgery, was operated by my professor, and she died. And that night, I stayed all night crying, and I even thought of changing my specialty. And when I consulted with my professor, he asked me only one question: was this mortality avoidable or not? Today in cardiothoracic surgery, which I will speak about because it's my specialty, we have a different atmosphere of training than when I was trained. Definitely today, there is a lower volume of regular cases, which were the bread and butter of the residents to train. We have more complex cases. We have more new procedures where the consultants need to train themselves. We have more technology. We have increased awareness of operating room utilization. So the slow resident is not accepted anymore. I'm sorry for the younger generation, but I feel that the youth or the younger trainees today are less eager to work, are less eager to pay the effort. I remember as a resident, I used to have a 20-hour working day. And right now, everybody is thinking of the family and the holiday. And we are fortunate in Egypt that we don't have the regulation you have in Europe. that forces residents not to work more than 48 hours. But I think the young generation is less eager to do the effort. To train a surgeon, I would like to start by this slide, which shows the anatomy of the surgeon. By training to skills in simulation or in OR, we are only concentrating on the practice and the dexterity of the hands. Surgery is not only about procedures, it's not only about skills. There is a lot to surgery more than that, which maybe is not covered by simulation. I learned mostly in this way, the regular way of apprenticeship, where you have an expert and you have a student, and then you see one, do one, then teach one maybe. Today, or this conference, this lovely conference, is speaking about simulation. This is the photo of the simulator of the 787 cockpit. I have a friend from KLM, and we shared some opinions about simulation just last week. And I found that in airline industry, simulation is used much more than in medicine. They have this type of simulator, which is called the Class D simulation, where, as Dr. Muller said, they try to simulate the real life with the atmosphere, with the problems, to train surgeons. One big difference between training surgeons and training pilots is that I discovered that the senior pilot has to go compulsory to the simulator at least twice a year, even if he is well trained. And maybe retraining is one of the aspects we surgeons should consider. I would like to tell this to the junior colleagues, the students especially. Everybody, when a student or a young surgeon, believes that these superhumans, the surgeons they see, they have special skills, they have special dexterity, and they are born like that. I would like to reassure you that that is not true. It's only a problem of practice. Most surgeons are exactly the same. Very few surgeons are handicapped, and the more you practice, the more you train, the better you become. We were always taught that practice makes perfect. However, it is not practice that makes perfect. I think it's perfect practice that makes perfect, like Vince Lombardi, the famous trainer, said. I have had my own share of experience with simulation, both as a student and as an instructor. As an instructor, I have had several courses of low fidelity simulation for coronary anastomosis. I've done 8 of them, 2 for mitrals, done mainly with very low fidelity simulators, or even with cow hearts or the similar. I have had my share of simulation as a student. At the age of 50, I decided to learn some new skills. So I decided to learn minimally invasive mitral valve surgery. And I had to go to several workshops where they use these simulators. I had to travel all around. It was very tedious for me at that age, maybe more than a junior surgeon would have done. But it paid. I learned, and then when I returned to Egypt, I had the burden of training all my team. Everybody, surgeons, anesthesia, perfusion, etc. Even the nurses. I have had my share of recognition, doing the first case in my country. And this is the actual wound of my first patient. And this is the actual surgical field from the very first case. Fortunately, our experience is growing. We've arrived at 64 cases with good results, which proved to me that you're never too old to learn. I get back to the anatomy of the surgeon, and I will see that there are some factors that cannot be taught by simulation. Dr. Muller has showed me that some of them can. However, with apprenticeship, we can learn some of the human aspects of surgery, some of the decision-making aspects of surgery. You need apprenticeship, you need a tutor to learn devotion. This is the famous painting, The Doctor, as you all know. To care for patients, to love patients, to share emotions with patients cannot be learned by simulation. When things go wrong, if we don't have the cockpit of the 787 they have in airline industry, you cannot train what to do when things go wrong by simulation. We need to learn from our failures. This is one aspect that needs people who discuss and share, and we need, as doctors, I think in all specialties, to find a platform where we can safely admit our mistakes. Obviously, it has been shown statistically that we are making millions of mistakes. We need to share them and not to repeat them again. We need to learn to communicate, and this is one of the skills a surgeon should learn, because the surgeon should communicate with his team, should communicate with his patients, relatives of patients, administration of hospital. We need to learn the value of teamwork. And these two pictures demonstrate two teams which I think operate in the same way. With the same, if they have the same harmony, it will probably produce the same music. Emergency situations, I withdraw this slide after Dr. Muller's lecture, but I think emergency situations should be taught by attending emergency situations more than anything else. A surgeon needs to learn courage, and at the same time, we should teach young surgeons to be courageous. We should also teach them when to stop. We need not to forget that one of our values as doctors is to care for the poor as well as the rich. Sometimes, and this is a particular situation, every surgeon knows, the interests of the surgeon and the patient conflict. Sometimes it's best to do the high-risk surgery for the patient, and this will not be beneficial for the doctor in his overall results and in the yearly evaluation. So I think when the interests conflict, the patient's interest should come first.
2 minutes, Dr. Yahia.
Okay. A surgeon should learn to be modest and should learn to be addicted to perfection. This is my idol in perfection, Kulthum, our famous singer, as you know her. And in Islam, this is what Islam tells us, that we should perfect whatever we do. Thank you very much. I would like to end by this.
Thank you, Dr. Yahia. And actually, I agree you 100%. Then there is an old statement which said, nothing can replace the kindness of the physician. Now it is time to visit Turkey, whereby Dr. Ismail is going to talk about interprofessional education, a platform of simulation-based medical education. Dr. Ismail.
Assalamu alaikum.